Kia ora and welcome to Goodfellow podcasts. This podcast was sponsored by an unrestricted educational grant from GSK. The content was developed independently by the Goodfellow unit and our expert speaker, Professor Nikki Turner, who has no involvement with the sponsorship. Today we are discussing RSV, respiratory syncytial virus, in adults. Professor Turner is an academic general practitioner and the medical director of IMAC, the Immunisation Advisory Centre at the University of Auckland in New Zealand. Nikki's interests are in immunisation, respiratory illness, primary and public health care. She resides in Wellington and works part-time as a general practitioner. Nikki sits on a range of New Zealand national advisory groups for the government, Ministry of Health and PharmAC, focused on clinical and policy advice around vaccine preventable diseases, the immunisation program and COVID-19. Academically, Nikki is widely published with over 100 academic publications in the arenas of immunisations, vaccination and child health. Kia ora, Nikki, and welcome back to the podcast.
Kia ora, thank you.
So today we're discussing RSV in adults in New Zealand. I wonder if you can outline for us how common RSV is in the adult population, and are there pockets of that population that the infection is more common in, and who are those that are more at risk of severe disease?
Yes, thanks, Louise. Well, as we all know, RSV globally is a very common and highly contagious viral infection. We see a lot of it in general practice. I suspect a great deal more than is actually recognised. RSV-associated peaks are particularly during the autumn and winter months. So that's major August in New Zealand, i.e. coming up soon. So the RSV infection itself actually disrupts our ciliated epithelial cells in the airway. They stimulate the white cells infiltration and they give mucosal edema. And the actual severity and the infectivity is directly related to the actual viral load. So majority of us actually see and experience RSV usually as a mild, maybe moderate upper respiratory tract infection. We get infected several times throughout our lifetime. Our first exposure is usually in infancy. And so by adulthood, most people have got pretty good immunity to RSV, although we do continue to experience infections with mild upper respiratory tract symptoms. So they would often be seen as colds. Preschool and primary school age children carry a lot of the infection and they tend to be a source of infection in the households and in the community. So they're the spreaders, as we know from our lovely children. The burden of severe disease, which is really the issue, is greatest at the extremes of age. So the severe diseases in the very young, and many of us will know it as bronchiolitis, and in the elderly, and then in people with significant comorbidities. We do have some quite good New Zealand data now on the burden of hospitalisation. We have active surveillance, and we have a research program that's been looking at that called the Shivers Research Study between the years 2012 and 15. And I'm talking now from data from a publication by Dr. Nam Prasad and her team in 2020. So this is just before COVID. And overall, when they were looking in the Auckland region at hospitalised acute respiratory infections, just under 8%, 7.6% of all hospitalised acute respiratory infections were actually RSV. The median length of stay was 4 days. Just over 1% died in hospital and over 3% within 30 days. And they figured out the cost per event was around $4,800. So really a significant burden in RSV that I suspect, until we look, we have not been recognising. There was really no difference also in risk factors between RSV positive respiratory infections and RSV negative. So when you end up in hospital with your respiratory infection, probably the source doesn't make a lot of difference. The research also calculated the burden by age group. And for midlife adults, they worked out an incident rate ratio of just under 6, but it rises steeply with age. And from about 65, you get an incident rate ratio going from 6 to just under 100. And then when you're 80 years and over, it's over 190. So this adds up to a 30 times higher rate for the older adults compared to younger adults. as we see with other respiratory illnesses, on top of that being of Māori or Pacific ethnicity, living in areas of higher deprivation are also associated with a higher risk of hospitalisation. So this all adds up to the fact that I think we underestimate the burden of RSV in elderly, particularly very elderly and those with significant comorbidities. And of course, the ethnicity factor is always of huge concern, with it being a much higher gradient. When you look at the international data, when you look at the comorbidities at higher risk, as you could expect, they're very similar to those identified for higher risk of flu. So I think in my head, when I think of adults in RSV, I think of the same high-risk comorbidities. It's really important to note that immunocompromised are way up there as being the highest risk. Down syndrome, important group to remember, frailty, living in long-term care facilities, and of course the drivers of increasing age and particularly underlying lung or heart disease. The likelihood of being admitted to hospital with RSV is 4 times higher if you have any significant comorbidity. But also I think we're significantly underestimating RSV. Like with flu, it may actually exacerbate underlying chronic conditions. So people may go on and have their heart attack or their stroke or their COPD exacerbation, and it may not be identified as being RSV associated. I think some of the other broader factors that we always need to think about with respiratory illnesses and RSV is up there: vitamin D deficiency, colder weather, air pollution, exposure to tobacco smoke. And of course, in New Zealand, we'd identify poor housing and overcrowded conditions.
Absolutely. Thank you, Nikki. So how does an adult present with an RSV infection?
Well, I think most of us out there in general practice are very familiar with adults presenting with respiratory illnesses. And really, RSV presentations are similar to any other viral respiratory illness. And I don't think we can easily distinguish them on clinical presentation. That's really unlike bronchiolitis, wheezy bronchitis in kids, which is so obvious. I think RSV presentations in adults can just mimic any other respiratory presentation.
So are there any investigations that we should be considering, and how is the diagnosis made?
Well, currently it's not. We just see an adult with a respiratory condition and assume the majority are viral. There are now good point-of-care tests available internationally. The RAT tests that we all got very familiar with in the COVID days, but they're not yet commercially available in New Zealand. So at the moment, you'd require a nasopharyngeal swab sent to a lab for a PCR as a gold standard. Now, that's not happening routinely in general practice and is not likely to. I think it would be nice to see these point-of-care tests available in New Zealand. I was part of a Shivers 5 respiratory study last year, Shivers 5 study led by Maria Stubbe and Tony Dowell, using point-of-care testing in some Wellington general practices in the after hours. And so you could take a rat swab and you immediately get your result for COVID, flu A, flu B, or RSV. This was incredibly popular, both with patients and providers. And I think it would be great for both our expectations, our education, and our management to have the virus identified on the spot. And hopefully it will help with better stewardship with our antibiotic usage. So it's not here yet, but I would hope we might move that way.
Wonderful. So tell us about the management of RSV infection.
Well, currently there's no antiviral treatment that seems to be particularly effective against RSV. So it's really the usual supportive treatment as we do with any other acute respiratory virus.
So prevention strategies, what should we be considering?
Well, the current prevention strategies are really about minimising contact and spread. And all those messages that we really learned effectively through the COVID pandemic really apply. Stay home when you're sick, keep good social distancing, particularly think frail elderly, people with significant comorbidities, immunocompromised. Keep away, keep your social distance. Remember cough hygiene, hand washing. We've learned a lot about good ventilation in houses and in our practices. Mask wearing in crowded places, particularly through the season of RSV and flu. I have to say I'm really concerned that we're all over COVID now and we're forgetting all these important issues. Combined, they're really helpful at reducing the spread of RSV. The broader environment, warm, dry housing, not being overcrowded, good nutrition, remember vitamin D, they're all likely to minimise the severity of our disease and disease spread. I mean, one interesting, extraordinary natural experiment we have just lived through in New Zealand with COVID is with the 2020 border closure, alongside our other non-pharmaceutical interventions, the extraordinary result was that we actually had no RSV at all circulating in New Zealand for all of 2020. Now, when New Zealand lifted the border restrictions initially just to Australia, early in 2021, within a few weeks, RSV returned and recirculated. And look, so many of us will remember that time when we had the sudden severe RSV outbreak and we saw loads and loads of respiratory presentations to our practices. I think the lack of any acquired immunity from a whole year may well have added to severity. And it also created an interesting shift in the age patterns where we saw increased diseases, not just in the traditional ages of young infants and elderly, but also in older infants, children, adolescents, and midlife adults. And many ended up being hospitalised. So it really made a difference. So following that atypical year, RSV has settled back into the more typical winter curve. But I think the importance of the story is not that we're likely to shut our borders again in a hurry, but the importance of non-pharmaceutical interventions, which people take for granted. I think we really need to think hard about these social measures. And I would also say, importantly for our general practices, continuing what we learned around separating out respiratory presentations. And I would advocate strongly for us all continuing to wear masks and keep good ventilation in our general practices.
Yes, some fabulous points there, Nikki. Thank you. I wonder if we can touch now on vaccinations. So are there any vaccinations available for RSV in New Zealand?
Yes, well, not yet, but soon. There are now a range of RSV vaccines and also immunoprophylaxis, which is passive immunisation, which are coming onto the market. Some are available now on the international market. There are in particular 2 adult vaccines available internationally and one that's very recently licensed in New Zealand. I think at this point, I wanted to touch on the history of RSV vaccination because RSV vaccination has started with a really difficult history, which is useful for us to remember. So the RSV virus has got 2 subtypes, A and B, and on their surface are 2 major glycoproteins. One's called attachment protein G and one's called fusion protein F. So the G targets our ciliated airway cells, but the fusion F, which is our main focus, fuses with the target cell membranes. Now, F protein is highly conserved across all RSV strains. So it was the original target for vaccine development. It's been a very stable protein. And the original vaccine development was in the 1960s. However, there was a disastrous start. Initially in the late 60s, there was a formalin inactivated RSV vaccine in development for young children. So in the early clinical trials, 100 participants actually caught wild RSV. 80% required hospitalization compared to only 5% of the controls, and actually 2 died. In hindsight, they realized this was due to vaccine-associated enhanced disease. So that was a real tragedy. There was at the similar time a live attenuated RSV vaccine candidate also unsuccessful due to adverse events. But that was related to poor attenuation of the virus. So for a long time, they paused vaccine development with that really tragic, terrible story until it was actually finally realized that the F protein has got 2 conformations. There's a pre and a post-fusion form. And antibodies against the post-fusion form have actually got low neutralizing ability, which following an RSV infection, they actually form immune complexes in the airways, and that drives an inflammatory response. However, the pre-fusion F protein actually induces a strong response only against the antigenic sites exposed in conformation and not against the post-fusion form. Hence, the pre-fusion F protein has been selected now as the target antigen, both for vaccines and for immunoprophylaxis now in development. Hence now the ability to make much safer RSV vaccines once they realised this.
Gosh, it's a fascinating story, Nikki. So tell us about what vaccinations there are available for adults and what's coming to New Zealand.
Yes, now that the science has figured all of that out, it's actually pouring through. So I think it is useful and important that we're aware of these. So all the current RSV vaccines in development are focused around the pre-fusion F protein, as we discussed, as the antigenic site for the body. And like there's a quite a wide range of technologies now being used for current RSV vaccines. And this is a reflection now on how amazing vaccine technology is. So they have in development live attenuated, chimeric, recombinant vector vaccines, mRNA, and the ones that are already out there on the international market are protein-based, subunit and recombinant subunit. I think it's important to be aware that alongside vaccines, there are also passive immunization technologies. This is called immunoprophylaxis, which are offered to infants. And so they use monoclonal antibodies. They are essentially pre-made antibodies that you deliver to give short-term passive protection to infants. So in many countries, including New Zealand, we've had a monoclonal antibody called palivizumab, which has been available only for very high-risk infants. And one injection offers a protection for around a month. So you have to offer it to the infants monthly through the high-risk season. But there is a new monoclonal antibody on the world market called nirsevimab, which gives much longer-lasting protection for at least 5 months to get an infant through the season. Sadly, it's not licensed or available in New Zealand currently. There's a world shortage. It's huge demand. And the US is using it in large amounts. And while it's looking highly effective, it's also likely to be very expensive currently, if and when we ever get access to it. So coming back to vaccines, there are 2 recombinant pre-fusion F RSV vaccines that have got regulatory approval internationally to date. So far in the States, in Canada, in Europe, and in Australia. And the phase 3 clinical trials are still ongoing, which will give further indications and further information. Alongside those 2, there's a range of further vaccine candidates in late-stage clinical trials, and we're going to see data coming out from more of these later this year and next year. So the first vaccine I want to discuss has got trade name RSV. Now, this vaccine, RSV from GSK, is an adjuvanted RSV pre-fusion F protein. It has just been gazetted in New Zealand by MedSafe at the beginning of April for adults 60 years and older. It is not yet available as I speak. However, it is expected to be available on the private market this winter from around mid-May. Initially, it's only going to be available through general practices, and it's likely and expected to be reclassified so that pharmacy delivery may be possible as well later this year. So the price to the provider, i.e. to us in general practice, is indicative only at this stage, but it's going to be somewhere around $264 to $300 per vaccine delivered as a single dose. There is data out to 2 years at this stage, and there's no decisions yet on whether later boosters may be needed or appropriate. So it's expensive, but it is a single dose, which is useful. So the vaccine contains the F protein stabilized. It's got a proprietary-based adjuvant called AS01E, and it's produced with recombinant DNA technology. It does need to be reconstituted, and it's stored at the usual standard cold chain temperature of 2 to 7 degrees Celsius. Now, interestingly, the adjuvant in this vaccine is the same as one we use in Shingrix, the recombinant herpes zoster vaccine, but it actually uses half the active ingredients. So it is expected, and it has been shown to be less reactogenic than Shingrix. So going back to the clinical trials, so the first stage of clinical development with this vaccine was in healthy young participants aged 18 to 49. And then once the clinical development progressed, they moved into adults 60 years and over. There are ongoing clinical trials and surveillance systems looking as the vaccine is delivered in real life, which will provide us with further information over time. An important little side note is they did have an unadjuvanted formulation in development for use in pregnancy, but clinical development was discontinued due to some potential safety concerns around a potential observed increased risk in preterm birth rates. I'll come back to that when I talk about another vaccine. So looking at the safety profile of this vaccine, RSV, it's looking good. The data from phase 2 and 3 clinical trials is very good. The reactogenicity is pretty mild to moderate for 1 to 4 days, generally 1 or 2 days. Some of the many vaccines, you can get injection site pain, fatigue and headaches. About 1 in 2 vaccinees get mild or moderate transient symptoms. You can get injection site reactions over 50%. You can get, soreness or itchiness at the site. There's very small amounts of headaches and fever. The reactogenicity, as I mentioned, is less than Shingrix, and it is less than mRNA COVID vaccines. There aren't any safety concerns about giving it co-administered with seasonal flu vaccines, but it is worth noting that twice as many had mild to moderate injection site pains when given with the seasonal flu. So GSK has reported to the ACIP, the American reporting, in October last year, that as of October, there was more than 2 million doses of this vaccine administered in the States, and the reported adverse events were reflecting that safety profile. So to date, the safety profile is looking good. Is it effective? Well, yes, efficacy is looking excellent. The pivotal phase 3 efficacy trial was on just under 25,000 adults, randomized 1-to-1 with a placebo, run in 17 countries. So it was quite diverse, and it is still ongoing. So over one season, vaccine efficacy was around 95% effective against RSV, lower respiratory tract infections, with confidence intervals around 66 to nearly 100%. So looking really good against severe disease. And it was still 81% effective in older adults with one or more comorbidities of interest. And the confidence intervals there were around 59 to 92%. So efficacy is looking really good. Results were similar in adults over 70 and in people with at least one comorbidity that increases the risk. And it was similar across RSV A and B, as you'd expect, because this is a conserved protein. So it is important to note in the clinical trials that they did exclude immunosuppression. They excluded unstable, very serious chronic illness or neurological conditions, excluded those with a survival expected less than 3 years. So there is no data to date on these groups, which of course are groups that are at very high risk of RSV. After 1 year and prior to the next year, they did give a second dose versus a placebo, but the second dose actually, interestingly, provided no clear additional benefit than a single dose provided over 2 seasons. Efficacy for the second season was still around 80%, with good confidence intervals, and around 67% against severe RSV. So it looks like it drops off a bit, but it still shows efficacy in the second year. So that's the vaccine that's going to be available very soon in New Zealand, and that's the one, firstly, we probably need to know the most about. But there is another one not far away. It's a vaccine called Abrysvo from Pfizer. We don't know when it's going to be licensed in New Zealand, but this is a bivalent vaccine. It doesn't have an adjuvant, but it's bivalent, containing recombinant stabilized pre-fusion F proteins from RSV subtypes A and B. Got 60 micrograms of each subtype. It's produced, for those who are interested, in Chinese hamster ovary cell lines using recombinant DNA technology. It's currently got regulatory approval in Europe, in the States, Australia, and again, recommended for use in adults over 60. Of note with this vaccine, it's also been recommended in pregnancy to provide passive immunity to the infant. So you give it to the pregnant woman, it's then passed across the placenta to give passive immunity against RSV, lower respiratory tract infections in neonates and infants up to 6 months. So that's an interesting indication for this vaccine as well. So at the moment, the Europeans recommend it being given in pregnancy between 24 to 36 weeks, and in the States from 32 to 36 weeks. Its safety profile, it's very similar to RSV. It's well tolerated during the clinical trials. It can be given concomitantly with seasonal flu. You do get a slightly increased risk of systemic responses. Again, reactogenicity is mild and moderate. I think the only thing that came up through the clinical trials was 2 cases of Guillain-Barré syndrome in the vaccinated in the phase 3 trial. It's very hard to know if they're associated or just coincidental, but this is something that certainly needs watching out for, whether there could be potentially an association with Guillain-Barré or not. Again, the trial endpoints, efficacy, this vaccine, to be honest, is looking at this stage like it's acting very similar to the other vaccine. It was initially trialled in young adults, 18 to 50. Interestingly, they first trialled it with a viral challenge study where they were actively exposed to RSV, and the vaccine prevented 75% of both symptomatic or asymptomatic infection, and was 87% effective against symptomatic infection over 12 days. It limited the peak viral load, and it reduced duration of viral shedding in those infected with RSV. So that was a very strong start. And then they ran the pivotal randomized controlled trial in about 34,000 adults over 60 years. And again, really good results. Vaccine effectiveness against symptomatic RSV, lower respiratory tract infection, of around 67%, and 85% against more severe, with pretty good confidence intervals. Again, efficacy looked good in older adults, pretty similar, and in those with comorbidities. And again, efficacy looked pretty good for at least one season. But, we'll see more data coming out on these. I think the interesting one about this vaccine is its potential role in pregnancy. They've got 2 clinical trials to date with interim results. The phase 3 trial used 1 dose in 7,358 pregnant women between 24 and 38 weeks gestation across 18 countries. Again, reactogenicity was good. The vaccine acted well. There was one warning signal. Again, the instance of preterm birth, it wasn't significantly higher in vaccinated to unvaccinated, but there was a suggestion that it could be. Vaccinated was around 4.9 to 6.5%, unvaccinated 4.1 to 5.5% at the time of the interim analysis. So this is just a potential risk for preterm birth, and therefore the US FDA took a cautious approach and had recommended the vaccine only between 32 to 36 weeks. So we need to see more data on this to see if this is a real safety signal or just one of those quirks where you see in a trial. Immunogenicity was really good. It worked well. Its vaccine efficacy looked for the newborn baby up to 180 days after birth of around 70% against severe RSV disease. So, an interesting one potentially in pregnancy. Now, finally, the next vaccine that we are likely to see soon is actually an mRNA vaccine called mRNA-1345 from Moderna. This has also undergone a pivotal randomized controlled trial of 35,500 people, 1-to-1 randomization on adults 60 years and above in 22 countries. And the interim results to date are also very good, with the vaccine efficacy somewhere around 83.7%, with good type confidence intervals 66 to 92% against severe RSV disease. So another vaccine that's looking very promising that we may see soon. It was well tolerated. Again, you saw injection site pain, fatigue, headaches, myalgia, but no significant safety concerns at this point. Moderna is expecting to get American approval by mid-May and potentially have it launched in the States after that. So vaccines are coming fast and looking good.
Wonderful. Thank you for that overview, Nikki. So when these vaccinations become available in New Zealand, who should we be offering them to as far as the adult population? What are the recommendations going to be?
Yes, so currently the only vaccine licensed in New Zealand is RSV. And so that's going to be this year the only one available on the private market from around mid-May. It's not going to come cheap. It's somewhere between $260 to $300. And we have to put our provider delivery costs on top of that. There is no decision yet from Pharmac about whether there's a place on the national schedule for RSV vaccines, and their decision is not imminent. So in the meantime, I would suggest for us, we think about high-risk groups in a very similar way as we do with the high risk of flu. Start thinking frail elderly, high-risk comorbidities. I would start thinking severely immunocompromised, heart, lung, kidney disease. I mean, sadly and frustratingly, price is going to be a significant equity barrier for many, but these vaccines are certainly looking excellent, and they do and should have a role in high-risk elderly.
So what are the recommendations internationally at the moment?
Yes, so of course they're not licensed in many countries yet. So the US is leading the way. And from June last year, they recommended both of the vaccines I discussed available for use 60 years and above as a single dose. They did note that clinical trials had excluded individuals with immunocompromise. And they did say, so the ideal timing would be prior to the typical RSV season. So for us, that would be very similar to when we use flu vaccine. In August last year, they recommended 1 dose of the passive immunity, immunoprophylaxis, nirsevimab, for all infants. And in September, they recommended a single dose of the pregnancy Abrysvo vaccine for 32 to 36 weeks gestation. So either could be given, either the passive immunity or the pregnancy vaccination. Now, the UK have been considering guidance, and from June last year, they recommended for infants the nirsevimab, the passive protection, or the pregnancy vaccination, the breastfeed, could be suitable for universal program for infants, and they did not express any preference for one product over the other. For older adults, they actually recommended starting with starting with 75 years and older as a single dose. That was deemed to be cost effective, but depending on how many years protection it may offer, because as yet, nobody's knowing how long these are likely to last.
Tell us about contraindications to vaccination, Nikki.
Yeah, so the contraindications are going to be similar to any other vaccine we've used. As the current vaccine will only be licensed for adults 60 years and over, we shouldn't be offering it to those under 60. The usual contraindications hold. You don't give it to anyone with an acute illness at the time of vaccination, with a fever, and anyone who has had anaphylaxis to any previous component of the vaccine, which is fairly unlikely, but that would really be the major contraindication. It hasn't been trialled in very frail and immunocompromised, but I would not expect any safety concerns in this group. It's just that the effectiveness is unknown. However, I don't think I would have any contraindications to giving it to frail elderly.
So when these vaccinations come onto our market, who should we be vaccinating or offering vaccination to?
Yeah, so I think the easiest way to consider is the high-risk adults is to consider it very similar to high-risk of flu. It does look like it's the same group of people. So the list in general, if you start before, think about immunocompromised, way up there is the highest risk. And then I go in my head down lung disease, cardiovascular disease. Diabetes is always a high risk. Neurological, neuromuscular conditions, as you'd expect. Kidney, liver, hematological disorders are way up there. And then anything else, you look at somebody and think this person is at higher risk of respiratory illness, they're going to be at higher risk of RSV. I think the factors that we probably never consider enough is frailty, advanced age, residential care and nursing homes. I think they're way up there as increasing risk for RSV. So really think of it like flu vaccines. Anybody who's at risk of respiratory illness is at high risk of RSV.
And can you just clarify pregnancy in that list? So at the moment, pregnant women would not be offered RSV vaccination in New Zealand when it comes?
No, at this stage, the vaccines coming into New Zealand are only 60 years and above. So the vaccine that could potentially be offered in pregnancy, if and when it came into New Zealand, is actually offered in pregnancy to give passive protection to the infant. Pregnant women are not really at higher risk of severe RSV, so it wouldn't be offered for the women's protection. If and when we get the vaccine, it would be a discussion about whether that or the passive monoclonal protection given to the infant is the better option to protect young infants.
So would we be thinking about grandparents in that situation, wrapping around for the infant?
I think we should be doing that now. If we think about newborn infants are at very high risk of RSV. We're just about to go into flu season. It'll also be RSV season. Protect newborn infants. If we did have vaccinated elderly, I think that would be very helpful. It's likely to, at least in the short term, reduce spread, as we saw from some of the early studies.
Wonderful, thank you. So you've mentioned that funding is not currently available and it will be a private market vaccine. I wonder if there is anything else that our listeners should be aware of.
Well, I think the clinical trial data is continuing to accumulate. So we need to watch real world experience in America and Europe and the UK as they use these vaccines. I think it's an advantage that we're not the first off the blocks here, but we will ultimately quite soon in the next few years have a range of choice of vaccines. We will have to decide on a decision around vaccination program, both for elderly and higher risk, but also for young infants. But until Pharmac decides it fits within their budgetary framework, and we're all aware at the moment how tight it is, it's initially going to just stay on the private market. And I suspect cost barrier is going to prevent significant uptake at this stage.
Well, thank you for your time today, Nikki. As we wrap up today's episode, what are your essential take-home messages for our listeners?
Well, RSV is well recognised as causing respiratory illness, severe respiratory illness in children and infants in particular, most often presenting as bronchiolitis. but it is less often recognised as causing illness in the elderly, particularly frail elderly and those with significant comorbidities. Now we have good adult RS vaccines coming onto the market. It is worth considering and thinking about the role of RSV, more importantly in adults. We will soon have one on the New Zealand private market. There is no plan in New Zealand as yet to introduce RSV vaccines on the national schedule, but other countries are considering and have already done so. So watch this space.
Wonderful. Well, thank you again, Nikki, for sharing your expertise on this topic. If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, please log this podcast. They are eligible. Thank you for listening.